Good morning, one and all. Welcome you all to the IHRS DM/DNB Cardiology Training Program. This is an initiative from the Indian Heart Rhythm Society to teach all the cardiology residents the basics in cardiac electrophysiology. We usually have topics distributed over ECGs, some certain discussions on intracardiac electrograms, certain discussions on practical aspects of device placements, and some theoretical aspects and very basic, which all the cardiology residents should know, like the timing cycles of pacemakers, ICDs, how do ICDs work and how do CRTs work. So this webinar scheduled today is again one another fascinating webinar. We have an excellent lineup of speakers. Let us get going without wasting much time. I would request our president, Dr. Ajay Nayak, sir, to start the proceedings with his opening remarks.
Thank you, Dr. Deep. You and Dr. Deba are doing a fantastic job of this series, and I'm sure a lot of DMD, DNB candidates are benefiting from it. Today's session is also a very interesting session with a good mix of ECG, EP, and pacing. And for this, we have fantastic moderators. Dr. Aditya Kapoor has already joined us, and Dr. Deba, Dr. Rajiv, Dr. Sumit should join. I'll hand it over to Dr. Aditya, and for the first presentation, he will start with the first presentation introduction.
Thank you, Dr. Ajay. So, as Dr. Deep already elaborated, this is a absolutely brilliant series which has been now, it was started some time ago, but today under Dr. Ajay's leadership, the IHRS has absolutely taken it to a different level altogether. So we were just, complimenting Dr. Deep and Dr. Deba for doing this every week so diligently. So thanks to Dr. Ajay. Thanks, Deep. Thanks, Deva. So today we have the first lecture is on ECG in narrow QRS tachycardia. We have Dr. Manish Rai, and followed by that, we'll have a basic lecture on how to do a basic EP study. So Dr. Arpita will do that. Arpita is from our institution. So I'm sure after that we have some topics on left bundle pacing. So it's going to be a really, really exciting day today, exciting academic initiative. So let's get going. And Dr. Manish, please have your slides.
Good morning, everybody. So I am dealing with a very basic but essential topic necessary for all DM candidates. So this is about ECG in narrow QRST. So when we talk about narrow QRS tachycardia, it generally means tachycardia with a QRS duration less than 120 millisecond. And the morphology is it's similar to sinus rhythm because most of these tachycardias originating above the bundle of His. So they look like sinus beats. So majority of these narrow QRS tachycardias are supraventricular tachycardias. But we should remember that, you could have VTs with a QRS duration less than 120 milliseconds. That's why the confusion in some of these tachycardias would be there between whether it's a VT or an SVT. Especially VTs arising close to the conduction system, which engage the conduction system very early, can appear as narrow QRS tachycardia or relatively narrow QRS. But by and large, when we talk about narrow QRS tachycardia, you're talking about supraventricular tachycardias. So some of the common examples would be sinus tachycardia, AV node re-entering tachycardia, orthodromic AVRTs, and the atrial arrhythmias, atrial flutter, fibrillation, atrial tachycardia, etc. So when we talk about narrow QRS tachycardia, understanding this is very important. So the circuit can be in one of these three places, by and large. So, either you're dealing with an atrial arrhythmia, either it's an atrial fibrillation, atrial flutter, or an atrial tachycardia. So here the circuit or the arrhythmia is in the atria. The AV node here is a bystander alone. AV node is not a part of this tachycardia. So these arrhythmias are AV node independent. The important is if you give an AV node slowing drug, you're not going to terminate these tachycardias. You might just slow down the ventricular rate. The second thing is because they are AV node independent, so they appear as irregular. So you could have an atrial tachycardia running at around 230, 220 beats, and some of these impulses pass through the AV node, some of them don't. So you could have the QRS would be irregular. So these generally appear as irregular tachycardias. And as a byproduct of that, you would have more A waves than V waves, or more P waves than QRS complexes. So, so generally, if you have a narrow QRS tachycardia, which is irregular, it clearly says it's an atrial arrhythmia. Either it's an atrial tachycardia, flutter, or a fibrillation. We should understand that some of the atrial arrhythmias can appear as regular tachycardias. For example, a sinus tachycardia can conduct 1:1, and it's regular. And the second is you can have an atrial tachycardia conducting 1:1, appearing regular. Some of the atrial flutters, for example, an atrial flutter at 250 might, every second beat might come to the ventricle, and you can have a ventricular rate at 125, still appearing as a regular tachycardia. So, while most, this one, what atrial tachycardias or atrial arrhythmias appear irregular, it's important to realize that some of them may be regular also. The second possible circuit is involving the AV node and a bypass tract, orthodromic AVRT. So here, because it's involving the AV node and it's a circuit, it appears as a regular tachycardia. It appears AV node dependent. So any AV node slowing drug is likely to terminate this tachycardia. And because you're having one QRS with one P wave, they appear as 1:1 conduction. So, and the P wave usually appears after some time because the circuit has to come down the AV node and go up and then activate the atria. So the P wave comes a little bit after the QRS. So, but this AV node, AVRTs appear as regular tachycardias, AV node dependent, have a 1:1 A and V relationship. The third circuit would involve exactly the AV node, not a bypass tract. So the typical example is an AVNRT. So here again, these are AV node dependent. Because they're AV node dependent, they appear as regular tachycardias, and they have 1:1 V and A. For every V, they have an A. But unlike an AVRT, wherein the activation of the atria occurs after the activation of the ventricles, in an AVNRT, because it is a very narrow, small area of circuit, the atria and ventricular activation is almost simultaneous. That's why many of the times we find the P waves buried within the QRS. So immediately after the QRS, you have a P wave and it's buried within the QRS. So these are the basic sites where these circuits can happen. So, you can realize that the first step in seeing an IHRS tachycardia is to see whether it's regular or irregular. If it is regular, it clearly tells you it's an atrial arrhythmia. If it's regular, it's either an AVNRT or AVRT. So in the third group, when I said that, the third circuit can be close to the AV node, like an AVNRT, we should also realize that some of the tachycardias arising in close proximity to this, like a junctional ectopic tachycardia, or an upper septal VT arising in the upper part of the septum, which can engage the conduction system very early, can appear as, narrow QRS tachycardias. But these, some of these might have a VA dissociation. So an upper septal VT might have more V than A. And so some of these in the third group arising close to the conduction system might actually not have a 1:1 VA, might have more V than A, but that's a rare finding. So approach to narrow QRS tachycardia, first is to see whether you have, A more than V. If you have more A than V, it's clearly an atrial arrhythmia. If you have V more than A, it is a very uncommon and rare subtype. Usually means either upper septal VT or a jet or something like that, very close to the conduction system. The more common scenario is wherein you have a regular tachycardia with 1:1 A and V. So these can either be short or long RP. So the first step in analyzing an IHRS tachycardia is see whether it's regular or irregular. If it is irregular, it is atrial flutter or an atrial arrhythmia, atrial flutter, fibrillation, or an atrial tachycardia. If it is regular, it's either an AVNRT, AVRT, or as I said, sometimes even an AT can appear regular. The second step, once you have a regular tachycardia, is look for the P waves. So here we see something called as an RP interval. So if the P waves falls in the first half of the RR interval, it is called as a short RP tachycardia. If the P wave falls in the later half of the RR interval, it's called as a long RP tachycardia. So short RP tachycardias, the classic examples are AVNRT and AVRT. The long RP tachycardia, the examples are sinus tachycardia, atrial tachycardia, PJRT, and atypical AVNRT. So these are the standard things that we need to remember. So this is a classic example of an SVT. You can see the first few beats are sinus beats. Then you have an ectopic triggering off an SVT. So if you look at this narrow QRS tachycardia, it's a regular tachycardia. So once we know it's regular, it's likely to be an AVNRT or an AVRT. The next step is to look at the P waves. You can see the small arrow marks. These are the P waves. The P waves are falling in the first half of the RR interval. So this is a short RP tachycardia. So here when we talk, we know our differential would be an AVNRT or an AVRT. Again, the P waves occur slightly after the QRS. So it could likely possibly favor an AVRT. So this is another tachycardia, narrow QRS tachycardia. It is regular. So we are kind of excluding an atrial arrhythmia. So it's likely to be an AVNRT or AVRT. The next step would be to look for the P waves. So, here the P waves, cannot be distinctively seen. They're probably seen as small slurs here at the S wave or as notches along the R waves. So when, likely that the P waves are hidden within the QRS or, within this. So this favors an avian RT. So the first step in an RQRS is to see whether it's regular or irregular. So sometimes whether it's an avian RT, AVRT is only a retrospective diagnosis. Once this tachycardias come to termination, you could unmask an underlying WPW, and then you know that the circuit involved was an orthodromic AVRT and not an avian RT. Secondly, are the long RP tachycardias. So far, what we saw were the short RP tachycardias. Now going to the long RP tachycardia. If you take for this example, this is a narrow QRS tachycardia. It's regular. Again, it can be an avian RT, AVRT, or an atrial tachycardia. So next step is to look for the P wave. Here, if you look, the P wave occurs in the later part of the RR interval. If you divide this RR interval into two, it falls in the later part of the RR interval. The RP interval is much bigger than the PR interval. So this is a long RP tachycardia. And I said the classic examples of long RP tachycardia are sinus, atrial tachycardia, PJRT, and atypical avian RT. Now, obviously, this is not sinus tachycardia because the P wave morphology is not upright in 2-3 AVF and inverted in AVR like what we expect in a normal sinus beat. So this is inverted in 2-3 AVF and upright in AVR. So this can be either an atrial tachycardia or a PJRT or an atypical avian RT. It's difficult to say with only this. We require more information like how how it responds to certain maneuvers or how the termination is or how the initiation is to differentiate exactly what it is. In this case, it was a Cox triangle atrial tachycardia. This is another narrow QRS tachycardia, again regular, says that it is either an avian RT, AVRT, or an atrial tachycardia. Second, if you look at the P wave, it's a long RP tachycardia. So, but the next step is to see the morphology of the P waves. If you look, the P waves look like it is sinus. It's upright in 2-3 AVF, but if you see it's inverted in one end AVL. This is not a feature of sinus tachycardia. Sinus tachycardia is always upright in one end AVL. So this is a tachycardia coming from the left atrium. So this is an atrial tachycardia again. So this again is a regular tachycardia, narrow QRS. So next step would be to see for the P waves. So here the P waves are exactly in between two RR intervals. This is here we need to understand something called as the Bix rule. So whenever you have P waves exactly in between two RR intervals, we need to look for more P waves. They could be hidden P waves. Here, if you look closely in lead 2, you can see a notch after the QRS. That is actually a P wave. So actually you have a atrial rate running twice at that of the ventricular rate. So this is an atrial tachycardia running at 2:1 conduction. So remember the fact that whenever you have P waves, exactly in between two RR intervals, you always have to be very careful to look for more P waves. One way to bring out the P waves would be to slow down the ventricular rate. In this patient, if you were to give a carotid sinus massage, a left carotid sinus massage, you'd probably bring out more P waves, and an underlying atrial arrhythmia would be obvious. So after going about regular tachycardias, we'll discuss a little about irregular tachycardias. So as I said, irregular tachycardias are atrial arrhythmias. Either they're atrial flutters, fibrillation, or atrial tachycardias. So next step, again, even in an irregular tachycardia, is to look at the P wave. So either you'll not have P waves, which is an atrial fibrillation, or you'll have regular P waves, which can either be a flutter or an atrial tachycardia. Differentiating in a flutter and atrial tachycardia is sometimes difficult. If you have an isoelectric line, it favors an atrial tachycardia. If you have continuous activation, it's a flutter. If you have multiple morphology P waves, it is a multifocal atrial tachycardia. We'll see a few examples. This is a narrow QRS tachycardia. And you can see here clearly, it is an irregular tachycardia. So irregular tachycardia clearly says it's an atrial arrhythmia. This is not AV node dependent. So, and next I would see the P waves. You can see there are no P waves or no discernible P waves. So this is an atrial fibrillation. Here, this is a narrow QRS tachycardia. It is irregular. So again, it says an atrial arrhythmia. Next step is to see for the P waves. You can see there are clear P waves in all leads, best seen in lead 2 and in V1. And you can see that the P waves are regular. So this is either an atrial tachycardia or an atrial flutter. So as I said earlier, a very useful tool in identifying or narrowing down narrow QRS tachycardias is to use a bedside maneuver called left carotid massage. When you give the left carotid massage, generally you slow down the AV node, and you'll unmask more P waves. So here, when we slow down the ventricular rate by giving carotid massage, you will see that there are obvious P waves which are running at a much faster rate, and they are regular. And this favors an atrial flutter. So in this narrow QRS irregular tachycardia, you see that the P waves are much more than the QRS complexes. And you see an isoelectric interval between P waves. So here the atrial rate is much higher than the ventricular rate. And you have an isoelectric interval between P waves. So this favors an atrial tachycardia rather than a flutter. So this is a narrow QRS irregular tachycardia, again suggesting an atrial arrhythmia. So next step would be to see P waves. You can clearly see P waves which are regular. And this is the classic P wave seen in a counterclockwise flutter. You have an undulating baseline, inverted P waves in 2-3 AVF, and upright in AVR, suggesting an atrial flutter. So, two maneuvers which can really aid in, identifying or, localizing narrow QRS tachycardia is one is the carotid massage, second is adenosine. Response to adenosine in these arrhythmias gives a lot of clues. For example, in an atrial arrhythmia, if you were to give adenosine, you would only slow down the rate, but you would hardly terminate. Rarely, atrial tachycardias can terminate with adenosine, but by and large, an atrial arrhythmia would not be affected by adenosine. So AVNRT and AVRT would terminate with adenosine. Again, the kind of termination would help you give you clues regarding what the arrhythmia is. So in a sinus tachycardia, if you give adenosine, you're going to slow down the sinus rates, nothing else. Automatic atrial tachycardias can sometimes, slow down or terminate with adenosine, especially, some of the atrial tachycardias. And in a flutter, it'll bring out the underlying P waves. And AVNO-dependent tachycardias are expected to terminate with adenosine. So this is an atrial tachycardia. So, when you give adenosine, the tachycardia is unaffected and you can see the P waves, running independently, but the ventricular rate being slowed down. So this is another atrial tachycardia which terminates with adenosine. So here you can see a narrow QRS tachycardia, long RP tachycardia. So it can be, either an atrial tachycardia, atypical AVNRT, or a PJRT. When you give adenosine, it terminates. So, this termination can be atrial tachycardia. So if this were to terminate with a P wave, it would rule out an atrial tachycardia. So generally, if the termination is with the QRS, it can be anything. But if the termination is with a P wave, it terminates at the AV node. So generally, it rules out an atrial tachycardia. So useful information with adenosine. Termination of a tachycardia with a P wave is typical of a AVNRT or an AVRT, and it kind of ruled out an atrial tachycardia. Termination with the QRS is seen in atypical AVNRTs, atrial tachycardias, and a PJRT. So continuation of a tachycardia with AV block suggests an atrial arrhythmia. ECG can also give insights regarding the mechanism of narrow QRS tachycardia. For example, an abrupt onset and termination usually means a re-entry, especially if it is initiated by an ectopic like the ones we saw. Gradual onset and termination, what we say is a warming up and cooling down phenomena, is more suggestive of an automatic arrhythmia. Onset with a sinus beat is suggestive of a PJRT. Spontaneous termination with P wave makes AT unlikely. So if you look at this ECG, a narrow QRS tachycardia, irregular, and you can see an ectopic triggers of a long RP tachycardia. So, so this is an ectopic triggering of a re-entrant tachycardia. So you can see the ectopic is of a different morphology from the next beat. So this is unlikely to be an atrial tachycardia, likely to be an atypical AVNRT. And this finding is classical of an automatic atrial tachycardia. So it comes in bursts. So, it's slightly irregular, narrow QRS tachycardia, and comes in bursts. So you have runs of atrial tachycardia, and then normalcy, and then reinitiation. There is typical warming up and cooling down phenomena, and it comes in bursts. So if you find this behavior, it's likely to be an automatic or a triggered atrial arrhythmia. So this is another example of slowing down of an atrial tachycardia, automatic atrial tachycardia. It's running fast and slows down before termination. So the initiation and termination also gives you a clue as to what arrhythmia you're dealing with. Finally, about the third subset, narrow QRS tachycardias, wherein you have V more than A. The two things we have to remember is one is junctional ectopic tachycardia and this one upper septal VTs. So this is an example of a narrow QRS tachycardia, which looks regular. But if you see clearly, there is V more than A. You have P waves which are positive in 2-3 AVF. So there's clearly VA dissociation. This is a junctional ectopic tachycardia seen in certain settings. In this case, it was a child with failure to thrive and it was heart failure. So this was a 19-year-old girl who was treated as an SVT. She was given adenosine, dilsem, everything with no response. And she was treated as an SVT because she had a relatively narrow QRS tachycardia. It is RBV morphology, but relatively narrow QRS. But if you look closely, although you have a regular tachycardia, you have VA dissociation. Here you can see P waves which are dissociated from the QRS. So this here you have a relatively narrow QRS tachycardia, but V more than A. This was an upper septal VT. So this is where the confusion happens. In a few cases, VTs can appear to be relatively narrow. As I said, VTs appearing close to the conduction system, upper septal VTs, etc., can look like narrow QRS tachycardia. So how do we differentiate is, we have to remember here the differential would be an SVT with a bundle branch block. So suppose you have an SVT which conducts with an RBEB or LBEB, it will look maybe something like a VT. But here the clue would be that any SVT which conducts with an RBEB or LBEB will look like a typical RBEB or LBEB. For that, we need to know what is a typical RBEB. A typical RBEB will have a monomorphic R in V1 and a slurred S wave in lead 1 and in V6. So if the tachycardia looks very similar to this, it's likely to be an SVT. So if you look in this picture, so you're not having the typical pattern of a typical RBB. You have deep S waves. Whenever you have deep S waves in V6, or you have AVR upright, or you have deep S waves in lead 1, it favors more of a VT than an SVT. That is all. Thank you.
Thanks, Manish. That was, I think, really nicely delivered, and I think you kept it very simple. I don't see any question in the chat box. So, first of all, Dr. Sumit is also here with us. So, welcome, Sumit.
Good morning, sir.
Yeah, so I think what I really liked about the lecture was you kept it so simple and it was a very, very systematic presentation. So, my carry home message before I think Dr. Ajay, I see Dr. Ajay as well. So, if anybody else has any comments, my carry home messages for all the students from this excellent lecture would be, first of all, see the regularity and irregularity, look at carefully the RP versus the PR interval. And a good thing which you taught was quickly see if the P is falling in the first half of the QRS versus the latter half. So, again, that's a good rule. Look at the response to a carotid sinus massage or adenosine. And you showed good examples of that fascicular VT. I think that is a great example because many times we see when the patient is referred to us, they are wrongly diagnosed as a narrow QRS tachycardia because the QRS appears narrow in a fascicular VT. But again, you look at AV dissociation. So you see varying STT humps. You see the STT morphology changing up very, very subtly. So that is where the P wave is following. And another great example, which I would again like to highlight, is the P wave falling right in the middle of the QRS. So again, that is very often missed. The look at the P wave axis as well, because long RP tachycardias, again, they are misdiagnosed as sinus tachycardia. So all in all, a great, great lecture and a lot of carry home messages. Dr. Ajay, Dr. Sumit.
Yeah, Dr. Manish, excellent images of ECG and good analysis. This was really nice. Couple of points, very general short points for everybody. If you're trying to look at a tachycardia, don't diagnose it by looking at a single lead on the monitor. You have to have a 12 lead ECG to determine whether it's a narrow or wide QRS complex tachycardia. What appears to be narrow on the monitor may actually be wide QRS. And also, whenever you're looking at the 12 lead ECG, you have to look at the lead which is showing the widest QRS to determine whether it is wide or narrow complex tachycardia. Because just in the last example, which Dr. Manish showed, the limb leads look pretty narrow, but the precaudal leads showed wide complex. So you have to look at the lead with the widest QRS to determine whether it's wide or narrow.
Excellent talk, Dr. Manish. Just
Any
few
comment?
points I would like to highlight. Whenever we have a tachycardia ECG and normal sinus rhythm ECG is available, we should always try to compare with that. There are certain clues which we get on routine ECGs or Holter, like we can have findings of dual AV nodal physiologies, or in a tachycardia Holter, if your P and QRS are not equal, like in AVNRT, P and QRS will always be equal. So that rules out AVRT. And also bundle branch aberrancies helps us to diagnose AVRT. Like if we have a change in cycle lengths with bundle branch block, like following Kummel's law, so that favors AVRT. Thank you.
So, Dr. Ajay, shall we move on to the next lecture or? And
Yes, so we should
hello, shall
can move
we?
on to the next one.
Dr.
Yeah,
Ajay, you
yeah,
are
we
on
can.
mute.
Yeah, Dr. Arpita
Yeah,
is going to
so
speak on how to perform a basic EP study. So,
Good morning, everyone. At the beginning, I would like to thank Dr. Deepchand and the IHRS team for this opportunity. I would discuss the basic EP study, how to perform it, how to analyze it step by step. So before starting the study, we need to get the patient ready. So we need to ideally stop the antiarrhythmic or rate control drugs that the patient is taking at least 2 to 3 days prior to the study. 6 hours of fasting is usually recommended. Heart preparation is required. 12-lead ECG is to be attached for monitoring. External defib pads in certain cases, RF patch for vital monitoring, pulse oximetry, and IVP or invasive BP as required, and conscious sedation in certain patients, especially children. Now we move on to vascular access. Ideally, for simple cases, venous access is sufficient. 3 or 4 venous access are required for catheter placement. Usually 6 to 7 French catheters are taken. Commonly, we use right or left femoral veins. Other veins that can be used include IJV or subclavian. And as per operator preference, type of arrhythmia, we take the number of access and the sites. Arterial access can be routinely taken by some operators for pressure monitoring, though NIVP is also sufficient in usual simple AVNRT cases. Right femoral artery is most commonly used, but it is mandatory to take arterial access if we are dealing with a left-sided pathway for transeptal puncture and if we require an retrograde access. So this is a typical how a setup is there in the EP lab. The patient is lying on the table. We have the surface ECG placed. We have the catheters placed at the different positions, diagnostic and ablation catheter. We have arterial or non-invasive BP over here. Then we have RF grounding patch and the foot switch. And then we have the connectors connected to the stimulator and the monitors, and finally being displayed at the display. So catheters have been discussed in previous talks. I'll just briefly re-explain that the catheters, the numbering of the catheter is from the distal, that is the tip, to the proximal part. So the first electrode is at the tip, and as we move proximally, we have second, third, fourth, and so on. We can have catheters from 2 electrodes to up to 20 or even more electrodes, and they are named as such. Moving on to catheter placement. Typically, we are seeing here the catheter placement in an LAO and an AP or an RAO projection. So here, if you see the first catheter at 12 o'clock position, this is the LAO view, this is the AP view, slightly RAO view. The 12 o'clock position in LAO is the his bundle catheter. Over here, it appears here. His bundle catheter is placed near the tricuspid annulus, abutting it and superiorly. Then we have the coronary sinus catheter, which is placed here from the IJV axis. It is placed here. We can see in the LAO view the spine, and it is going posteriorly towards the spine. This is the CS catheter, a decapolar catheter. In the AP view, we can see it is like over here. Third, that is the most common catheter that all the DM students are familiar with, is because they do the TPIs regularly, is the RV catheter. This is the catheter placed at RV apex. In the AP view, RAO view, it seems coming into the screen. And finally, we have the RF catheter. Depending on the site of ablation, it is placed accordingly. Once we are familiar with the catheters are placed properly, then we'll move to the basic EP study. This study, first of all, we have to measure the basic baseline intervals. Then we'll do some maneuvers and pacings, pacing the ventricle as well as the atria. For ventricular pacing, during ventricular pacing, we assess the retrograde conduction and refractoriness and induction of arrhythmias. Atrial pacing, we assess the sinus node automaticity and conductivity, AV node and his Purkinje system conductivity and refractoriness, and the induction of arrhythmias. So before starting any EP study, it is a good practice to first look at the baseline ECG. And doing this, we can rule out WPW, any baseline bundle branch block, which helps in further assessing our EGMs during the study. Surface ECG is placed on the top of EGMs for correlation. So especially for beginners, it is better to correlate the surface ECG with the EGMs for better understanding of the EGMs. We know the ECG is usually done at a speed of 25 millimeter per second, but at this speed, the EGMs appear very cluttered. So for highlighting the EGMs, for spreading out their signals, we use higher speeds, 100 to 400 millimeter per second. At this speed, the surface ECG appears a bit distorted, but we are able to see the QRS sufficiently to analyze it. Now, how we see, once we have placed all the catheters in the high RA, his bundle area, coronary sinus, and RV apex, and a catheter placed in the high right atrium will show an A wave on the intracardiac electrogram. Catheter in the His bundle area will show 3 deflections, an A wave followed by a His deflection and followed by a V deflection. Coronary sinus catheter, as I discussed previously, the first, second electrode are towards the left side, whereas the 9-10 electrode are towards the CS pause. So this also shows an A wave and a V wave. And finally, the RV electrode waves at the apex, this will only show a V wave because it is placed in the ventricle. So normal sinus rhythm, the conduction, if we compare it with the surface ECG, we have the surface ECG P wave. The first activated chamber is the high right atrium, followed by the his system, his A wave, H and V wave. After his A deflection, we go to the CS 9-10 towards the cos. Will be in sinus rhythm will be first stimulated, followed by CS 7-8 and so on towards CS12, which is present on the left side. And finally, we have a His deflection and then a V wave. This is a normal sinus rhythm activation sequence, starting with the high right atrium, where the sinus node is present, moving to the His, and then the other CS leads, and finally, H and V waves. Now moving to some basic concepts which we use frequently in the EP study. First is cycle length. What is the cycle length? It is the interval between 2 consecutive normal or paced atrial or ventricular signals. Shorter the cycle length, faster is the rate. So how we calculate the cycle length is basically rate in beats per minute is 60,000 divided by the cycle length, and this is in millisecond. So for reference, if the heart rate is 80, the cycle length is 750 millisecond. If the heart rate is 100 beats per minute, it becomes 600. At 150, it becomes 400 and so on. So as the heart rate will go on increasing, the cycle length will become lesser in number, but faster. So on the EGM, this is how an EGM will look like. These are the surface ECG followed by the CS from 9-10 to 1-2 we have arranged, since the normal sinus activation is from 9-10 towards 1-2. And in the His bundle, we can see an A deflection corresponding to the P wave, an H in between, and a V wave corresponding with the QRS complex. So the cycle length is measured in between 2 A intervals in the atrial catheter, either the sinus or the CS or the HRA. Now the baseline parameters, the AHV intervals, which are the first to study in a basic EP study. So this is the cycle length. We have already discussed the CS arranged from CS. Here the 9-10 is not there. So CS 7-8 is the earliest and so on towards CS 1-2. And then we have His A, H and V. So AH interval is measured in the His catheter from the beginning of the A to the beginning of the H. Here it is 60 milliseconds. HV interval is measured from the beginning of H in the His catheter to the beginning of the QRS on surface ECG. Here it is say 46 milliseconds. Elaborating on these baseline intervals, there is also a PA interval, which is described from the onset of the P wave in surface ECG to the A in His bundle. What this shows is intra-atrial conduction time, which is normally 25 to 55 milliseconds. Then we have the AH interval from the onset of A to the onset of H in this catheter, as I described previously. This represents conduction time through the AV node. Normally, it is 55 to 125 milliseconds. The H time is measured from the onset to the end of the His bundle recording, which measures the conduction time through the His bundle, which is normally less than 30 milliseconds. HV interval is from the onset of His deflection to the onset of the QRS in surface ECG. This represents the conduction time from the His bundle to the ventricular myocardia, which is normally 35 to 55 milliseconds. Now, in the absence of pre-excitation, the normal HV interval is 35 to 55 milliseconds. Now, let us look at this. Here we have the surface ECG and the EGM showing the CS and His deflection. Now, we can see here that the surface ECG shows a prominent delta wave. Now, when I draw a line from the His deflection, this is the His distal, you can see an A, H, and a V wave. If I draw a line from the His deflection, you can see that the QRS is starting before this His bundle. So a negative HV deflection may be seen in WPW syndrome, or a very short HV interval may be seen. A prolonged HV interval is usually suggestive of infranodal conduction abnormalities. Now we move on to the pacing. We can do pacing in ventricle as well as the atria through different maneuvers. Different types of pacing are there. Ventricular pacing, we usually use incremental or extra stimulus. What we want to assess is the VA conduction through the AV node or the accessory pathway. Absence of VA conduction usually is suggestive of less likely AVRT or AVNRT. Decremental ventricular pacing. Here, continuous pacing is done from the RV apex at faster rates that is shorter cycle lengths until we achieve a VA block. And extra stimulus testing, here multiple electrical impulses are administered at fixed cycle length, usually 6 to 8 in number. This is followed by a premature beat. Coupling interval is the time from the last this fixed cycle length is known as drive chain, 6 to 8 beat, and this premature beat is known as extra stimulus. So the distance between these two is the coupling interval, which is progressively shortened in the each next cycle. So this is an example of a drive chain. Here we can see S1 is say 500 millisecond. We are delivering 6 impulses at this, followed by an impulse which is say 350 millisecond, which is faster than the drive chain. So this is the drive chain of 6 impulses followed by an extra stimulus. Now moving to this EGM tracing, what we can see over here is, see the RV channel over here. The ventricle is being paced. As we can also see in V1, we can see the QS. Now you see the CS. It is showing a deflection. But what we see is that these QRSs are more in number as compared to these A waves. 2 QRS followed by 1 A wave. So there is no clear-cut 1:1 conduction between the V and A. So this is what is known as VA Wenke-back. The point when we start pacing, gradually we increase the rate of pacing, make it more faster. So there will be a time when all the V's will not be conducted to the atrium, and that is when the 1:1 VA conduction is lost during RV pacing. This is known as VA Wenke-back. Another case of an RV pacing, how do we identify? This is the stimulus just occurring before the QRS in the surface ECG. V1, we are seeing the QS. V6, we are seeing an M pattern. So RV is being paced. Now, this is a drive chain. We had 4 stimuli previously. The 5th and the 6th stimuli are shown here in the drive chain, followed by an extra stimulus, which is occurring at a faster rate. Now we can see in the CS, the conduction is from 910 towards 1-2. That means it is going in a central direction, followed by, here we can see his bundle, pacing spike V followed by A. Here, pacing spike V followed by A. The V to A distance has increased. So this is known as decremental VA conduction. And the earliest A, as we can see, these are the A in the CS, and this is the A in his bundle. The earliest A is occurring in the his bundle catheter. So that means earliest A in HV with a decremental conduction in VA. This is the property of AV. Now we can also analyze the refractory periods retrogradely by V pacing. Again, we are pacing the ventricle. S is the stimulus we are delivering. In the his bundle, we can see a V wave followed by since we are pacing the ventricle, RV pacing it over here in the RV catheter. His bundle, we are seeing the V wave, and CS, we are comparing the A wave. Second stimulus followed by a V and a A wave. What is happening in the third stimulus? After we deliver the third stimulus, there is a V, but we do not see any A. There is a QRS, but there is no P wave here. So what is happening is that the impulse is getting blocked from the ventricle to the atrium. This is known as ventriculoatrial effective refractory period. Next example, again we are pacing the ventricle. See the QRS. Now, after pacing this ventricle, we are seeing the V in the, this is catheter in the RV, V and A, V and A in CS. Third beat, V in the RV catheter, A in the CS. What is happening after that? We are getting a spike. There is no V. How do we confirm it? There is no QRS in the surface ECG. After the third V, so there is a pacing spike, there is no V and no A. That means that the impulse is getting blocked in the ventricle itself. This is ventricular effective refractory period, which is normally 170 to 290 milliseconds. Another example of V pacing. What else can we do for ventricular pacing? There's a drive chain followed by an extra stimulus. What is happening over here? Instead of a central conduction, where the CS 9, 10, 7, 8 towards 1, 2 happens. Here, what is happening is the earliest A wave is in CS 1, 2, then 3, 4, 5, 6, 7, 8, and so on. And his bundle A is late. Similarly, in other beats also, this is suggestive of an eccentric VA conduction, which is seen in left-sided accessory pathway. Another example of, this is a very interesting case. Another example, we are pacing the ventricle. What do we see in the first two beats? Look at the CS channel, CS78 to 12. The conduction here is from CS78 towards CS12. And A wave is in bundle is the first, followed by 7-8 and so on towards 1-2. This is central conduction. Now, in the third beat, what is happening is that his bundle A becomes late, and the conduction is now from CS12 towards 7-8 and so on. So once we have overcome the refractoriness of the accessory pathway, now the conduction is through the left-sided accessory pathway. So there is change from nodal to accessory pathway conduction in this case. Moving to atrial pacing. Atrial pacing, what we can do with this is antegrade AV nodal conduction. We can check antegrade refractory periods, any AH jump, AV nodal echo beats, and induction of tachycardia. So how do we identify whether which chamber is being paced? Look at the pacing spike. This is occurring before the P or before the CS in A. So that means this is the pacing of the atria. We are giving the drive chain followed by an extra stimulus, which is faster. And we can see the CSA. We can see H and V in the his bundle and so on. All are getting conducted. Now another case, here also the pacing spike followed by a deflection in the CS A wave. That means we are pacing the atria. Now we are delivering the drive chain followed by an extra stimulus, which is faster. Here we can see there is in his bundle, there is an AH followed by a V, another AH followed by a V. After the third spike, there is an A wave, but there is no H, no V. So it is getting blocked in the AV node. This is known as an AV nodal effective refractory period with normal values of 230 to 425 milliseconds. The next case, we are pacing the CS again. Pacing spike followed by an A in CS. First beat, second beat, third beat. This was a drive chain followed by an extra stimulus, which is faster. What we can see over here, first two beats, we can see an A, H, and V in his bundle catheter. Second beat also A, H, and V. The third beat, there is a pacing spike. There is no A and followed no H and no V. So this is getting blocked in the atrium itself. This is known as atrial effective refractory period. The normal range is 170 to 300 milliseconds. The next case, again, we are pacing the atria through the CS. We can see pacing spike followed by deflection in the CS catheter, the A wave. If we see the number of A waves over here, so we can see there are more number of A waves as compared to the V or the QRS. So when we keep on pacing the atria at progressively faster rates, there will come a time when all the A waves will not be conducted to the ventricle. This is known as AV vector. Point where 1:1 AV conduction ceases during atrial pacing. Next example. What is happening over here? We have a pacing spike. This was a drive chain followed by an extra stimulus. Pacing spike A, H, and V in the his bundle. The second pacing spike, there is an A, and H is coming after a long jump. This is known as AH jump. Abrupt increase in AH interval of more than 50 milliseconds. Now following a decrement of 10 milliseconds in the S1, S2 coupling interval. This is known as AH jump. Property of a dual AV node physiology suggestive of likely AV NRT. Another example of pacing the CS. We have CS pacing spike followed by an A wave. AH jump is there, prolonged AH interval followed by a V wave. Now what is happening is this impulse, it traveled from the atria to the ventricle through the slow pathway in the AV node, came back to the fast pathway. Again, antegradally went to the slow pathway, came back to the fast pathway. It generated 2 beats. These are known as echo beats. If this continues, it will induce the AV NRT. These are 2 AV nodal echo beats. Another example, here we are pacing the atria drive chain followed by an extra stimulus. We are having an A wave followed by an H deflection and a V wave. Again, we can see the impulse is traveling through the slow pathway, antegradally, retrogradely, going to the fast pathway. So this is shorter. Again, generating an echo beat, and now this induces a tachycardia. We have a sustained tachycardia going to the slow pathway antegradally and fast pathway retrogradely. This is what is known as a slow fast AV NRT, initiated with a AH prolongation or a jump. Another example of the same tachycardia, what is happening over here is you can see the QRS in the lead V1, and we can see the CS channel showing the A wave. Now there is a continuous tachycardia going on. This tachycardia, or it appears that the V and the A are in a straight line. Very little distance between the QRS and the A wave. This is known as V on A tachycardia. Here also the earliest A is in his bundle. So this is classical for a slow fast AV NRT. Here the VA interval is less than 70 milliseconds. And if the VA interval is more than 70 milliseconds, it may be an AVRT or an atrial tachycardia. Easiest way to identify is that all the CS A are falling in a straight line with the QRS in the surface ECG. Another example of a tachycardia initiated after A pacing. What is happening over here? If we look at, first of all, the QRS is wiped away from the A in the CS 910. Now, second thing, we'll see how this is getting, how the atrial channel is getting, the impulse is getting conducted. So we can say the earliest A is in CS 1, 2, and 3, 4, and towards 9, 10. So that means left side is getting stimulated before the right side. And you can see the his bundle A is late. So CS 1, 2 is the earliest to get activated, then towards CS 9, 10, and his bundle A is late. B and A are separated, so there is an eccentric conduction. This is classical of an orthodromic AVRT. And here you can see the CS arranged from 1 to towards 9, 10. So it is getting started from the left side and accessory pathway. So the first impulse is in the CS 1, 2, then move on towards CS 9, 10, and it is getting eccentrically conducted. Now, a little bit in brief about the sinus node function testing, which can also be done through pacing the high right atrium. First is the sinus node recovery time. This is the longest pause from the last paced beat to the first sinus return beat at a particular pacing cycle length. HRA is usually used for pacing near the SA node SVCRA junction, and the rate is 20 to 30 milliseconds faster than the sinus cycle length for 30 to 60 seconds and then stopped abruptly. This is how it looks like. We have S1, the stimulus, which is HRA being paced at a fixed rate for 30 to 60 seconds, stopped abruptly. Now the time taken from this last paced beat to the return sinus beat. This is known as sinus node recovery time, the time taken by the sinus node to recover. Property of the automaticity of sinus node can be seen through this method. Interval between the last paced beat and the first returning sinus beat. Normally, it is less than 1500 milliseconds. There is also something known as corrected sinus node recovery time, which is the difference of the sinus node recovery time minus the sinus cycle length, which was there in the beginning. So normally it is 350 to 500 milliseconds. Now, the issue with this method is that at different pacing rates, the sinus node recovery time and the corrected SNRT will be different. So we have to pace at different cycle lengths, starting with a faster rate. Say the sinus rate is at 600 milliseconds. So we start pacing at 500, then 400, then 300, or at 50 millisecond difference. We pace 5-6 times. We see the SNRT at each pacing cycle length. And then we calculate the longest SNRT, and that is the one that is considered. So basically, if this is prolonged, then that is suggestive of sinus node dysfunction. Another thing is sinoatrial conduction time, SACT. This shows the conduction property of the sinus node. Conduction time between the sinus node and the adjacent atrial tissue. Return cycle curve. What we actually doing is, this is the normal sinus. 2 sinus beats are occurring. Now we are delivering an atrial extrasystole. And we calculate the time taken by the sinus node to recover from this to normal sinus beat again. So after delivering the AES, just before next spontaneous sinus cycle, and this will reset the sinus node. So we calculate the interval between the paced stimulus and the next sinus cycle beat. This is known as return cycle length. And the difference between the return cycle length and the baseline sinus cycle length when divided by 2, this is known as atrial conduction time. Normal values is 50 to 125 millisecond. And what this shows is the conduction time between the sinus node and the adjacent atrial tissue. There are multiple methods to do this. We can also measure it directly, but that is a challenging procedure, a cumbersome one. This is an easier method. This is known as the Strauss method. We can also do it by other methods, by continuous pacing as well. I think I will end here.
Dr. Rajiv, is Dr. Rajiv there?
Yes, sir.
Dr.
Yes, sir. So should we move on to next session?
Yeah, I think I particularly like the way Dr. Arpita presented it. So maybe Dr. Ajay can or Deep can comment, because
there are many maneuvers, many ways of doing it. What you need to know is, for every EP study, have a protocol in your mind, and you do that every time for every patient. So you should not miss out on anything. Have a sequence in your mind, and you have to follow that. If you do things haphazardly, if you miss out on certain things, you're likely to get more confused, and the procedure becomes longer. So in your mind, you have to be aware of what you're doing, why you're doing, and you do the same things in every case, so you have proper information.
Nice flow of the slides, both the previous speaker and this one. The maneuvers have been shown well. So as Dr. Ajay said, keep the maneuvers, everything in mind, and go systematically. So if you go systematically, follow a particular protocol as Arpita also showed, so you will not miss too many things. So good presentations both.
There are some questions in the chat box. What we'll do, Aditya, is probably take them in the end. If we have,
There was
because
some
there are a lot of questions on the previous lecture also and this also.
previous one I tried to address it ongoing because Deep said कि हाँ तो इस पे भी हैं, so maybe we can take it in the end or whatever.
Deep, what do you think? Should we take them now or later?
Yes, I mean, a few minutes we'll try to. We have some time, 5 more minutes left before the session gets over.
So
We'll
maybe
finish
Dr.
this because,
Aditya, Dr.
yeah,
Rajiv, we can just go through the
go through
questions
this.
quickly.
So we had chat. One question is there. Atrial tachycardia can have VA conduction less than 70 milliseconds. AHM not shown properly. Two different S1, S2 coupling intervals should have been shown. Yes, you're right, but due to lack of time, as Dr. Arpita has shown AHM nicely, but yes, you are right. There should be two extrasystole to demonstrate AHM. But what she was trying is just to have idea about how AV nodal refractory period is calculated, how air jump is seen. So that's why I think we should cover in next session or so. And one more question is there.
Yeah, but it's a
Could you
practical
please?
question. I would like, Kapoor sir, Rajiv, and yourself as well, all of them, to give your tips as experienced, people who have been in the EP. They have difficulties in putting the HIS catheter, CS catheter. Is there any specific maneuver that you follow to place these maneuvers? Very simple. Like you take the catheter inside the heart. So is there any specific thing that you would like to say? That use this, you will get to the HIS, or use this, you will get to the CS. Yes, sir.
So, hello? I'm audible?
Yes, sir. Yes, sir. Please go. Yeah, yeah.
So, to place catheter in coronary sinus, what we have to do, we have to go into the RAO view. First, go into the RV. Then, as we go with TPI, then flex it and pull it and keep it at annulus. Then go to the LAO view. Keep the catheter flexed, rotate it clockwise, and pull it slowly. Usually it goes into the coronary sinus. Just it enters the coronary sinus, just deflex it. Mostly it enters into the coronary sinus. It is easier with St. Jude catheter compared to J&J catheter. And regarding HIS catheter placement, we again we have to go into the RAO view, same RV entry, and then we have to pull the catheter slowly. If we have CRD2 catheter, which is designed for HIS only, then it usually stays at the HIS area and we can see his signals well. Usually HIS is seen, as we know, upper part of the annulus and CS is at lower part of annulus. CRD2 catheter is the catheter which usually sits at the HIS position. Sometimes you have to do maneuvers and in LAO view, HIS catheter is seen end on. So you have to see in both views. Dr. Deep, you like to say anything else?
Yeah, I mean, and all is good. Yeah, everything comes with it. There's nothing rocket science here. So utilizing RAO and LAO views is very crucial. Like anything in interventional cardiology, don't stick to only one particular view. And then, getting to the inferior or annulus for the CS in the RAO view, and the superior most part of the tricuspid annulus is where the HIS is in the RAO view. You should be able to get to these CS placements. And there are institutes and centers which routinely place via the jugular route as well. And in the jugular route, again, it becomes very easy placing the CS catheters. If you're someone who is starting out to place the CS catheters, it will be much easier to get into the jugular route, even without a catheter which has a flexion capability, like a catheter which you get into the RV, pull back, and then with an anti-clock, and you should be able to get into the CS and push yourself into the CS. Ajay, sir, you have anything more to add here? Particularly, people have asked, they have difficulties in placing the CS catheter in the initial days. And then we have had a separate discussion on catheter placements. We have in the prior IHRS webinars, we have discussed this, and then we have put it on the IHRS website. Would encourage you to visit those webinars.
Each individual patient will be slightly different, so don't get bogged down by it. Don't keep You have to do something maybe a little different for each patient. The cardiac topology may be a little different. It's not your problem, it may be a problem of the anatomy. You may have to change the catheter curve from a medium to a large, or depending on the cardiac size. In case you don't want to do interjugular, you can actually put a catheter from the left antecubital vein, decapolar 5 French, into the coronary sinus. If you don't want to do a central, all these are various techniques. There are various things which can be.
Yeah, there were various ways. Very true. I've known electrophysiologists as routinely place left subclavian axis. They take a left subclavian axis and get into the CS for the CS catheter placement. And they have no vascular issues as well, who are so used to placing subclavian venous catheters as well. So, yes, sir, I think it's Dr. Sumit, you have anything to add? You can add, and then we can move on to the next session.
Just for the people who are just starting and entering into the EP lab, it's difficult to understand the EGMs if it is given at once. So it's always better to analyze the sinus rhythm and move ahead in a proper way so that you should not miss the important thing. Like first, just analyze the EGM of the sinus beat. What is the H interval, which will give you the AV nodal conduction? Then HV interval, short HV will give you clue of the accessory pathway. Then we do some maneuvers in the sinus rhythm like V pacing and atrial pacing to see the eccentric activation of the atrium or centric activation. Then we induce the tachycardia with atrial pacing or ventricle pacing. Then we analyze the tachycardia, like what is the relation of A and B and what is VA interval and all. Then we do some maneuvers during the tachycardia. And finally, we reach the diagnosis and finally we move ahead with the ablation. So this is the sequence which we usually follow in each case. That's it.
I
So,
think pretty good. Yeah.
yes, sir. Yes, sir.
Yeah, I think we can go on to the next session. Should we?
Yes, sir.
Okay.
Yes, sir.
Yeah, and it's a great pleasure to introduce Dr. Shanmugh Sundaram. Dr. SMS has been the pioneer in conduction system pacing in our country. He's done numerous publications, and worldwide he is known for his work in conduction system pacing. He is considered an international expert in this. So it's a real pleasure having Dr. SMS here. It'll be excellent for him to introduce, and we can have the other talks after that. And Dr. SMS, you're welcome to give your tips even for the subsequent lectures.
Sure.
Go ahead.
Thank you, sir. Once again, I'd like to thank IHRS for giving the opportunity of discussing about, again, my favorite topic, left bundle branch pacing. Hope my slides are visible.
Yes, all good. Go ahead.
So, so the idea is to discuss about the procedure in a step-by-step way, which I'm doing it for the last 5-6 years, I think. I hope I'll not bore, and at the end of the session, I think every beginner will be able to do good justice for conduction system pacing for all the patients. The whole idea of doing conduction system pacing is to re-establish the electrical synchrony. We know the fibers inside the His bundle are longitudinally dissociated. So if you have a segmental disease affecting one part of the His bundle, so you can have either a right bundle branch block or left bundle branch block. When there is a complete transaction, it will ultimately end up in a complete heart block. In fact, almost 95% of complete heart blocks occurs because of intra-Hisian disease rather than infra-Hisian disease. So all you have to do is put the lead just distal to the site of block, either in the distal His bundle or in the proximal left bundle, to correct either left bundle branch block or right bundle branch block or complete heart block. The first step in conduction system pacing is to identify the His bundle. So it's our customary practice to place 2 catheters from the groin. So if you have an EP system, put a quadripolar catheter, like in the previous session, we were discussing about the CRD2 catheter, which stays there throughout the procedure in the His bundle location. This can be placed in the his bundle, and you can do a quick map within few seconds to identify the extent of his bundle and mark the distal extent of his bundle fluoroscopically so that it can be used as a reference. So another catheter will be placed into the right ventricular apex to identify the RV apex. And remember, this should be placed in right anterior oblique view. So 25 to 30 degree, depending upon the patient's heart orientation and the operator's comfort zone. You can have an RAO view, place the catheters, take a cine, and use this as a fluoroscopic reference landmark. His bundle pacing, which people are largely doing these days, but I feel every one of us should know how to do a his bundle, because it sometimes salvages the difficult left bundle procedures, which in fact happened to me a year back, where we had a difficult left bundle and we ultimately end up in putting the his bundle in. So when you have a groin his catheter in the his location, all you have to do is take the sheath along with the catheter pacing lead to the distal extent of that quadripolar catheter, map the signals over there. So all you have to do is get a very small a decent his signal, and a large ventricular electrogram. So this will essentially tell you that you are in the distal extent of the his bundle, just crossing the tricuspid valve in the ventricular component of the membranous septum. So you have to cross the tricuspid leaflet to cross the ventricular aspect of the his bundle, which ultimately tells you that it's a distal his bundle, so that you will have a good ventricular sensing, you will not have any atrial oversensing, and you will have a good his bundle capture threshold. So once you deploy the lead over there, you will be able to see a good current of injury, and this current of injury will be seen in the unfiltered electrogram between the his potential and the ventricular electrogram. Remember, this filtered electrogram will not show the current of injury, only the unfiltered electrogram will show. And this current of injury ensures you that the lead will stay there throughout the patient's lifetime without giving any concern about rising threshold. So either it is a nodal block, infranodal block, the his bundle pacing will correct it. The real problem occurs in white QRS, where you may have to go for a complete scanning of his bundle to identify the disease-free segment. Then you have to deploy the lead at the right spot. So let me show a case-based example. This holds good for either his bundle pacing or a left bundle pacing. So this is a white QRS, left bundle branch block. We did a quick EP study, and we placed the catheter just proximal to the site of a so-called disease segment, where we got a HV of 85 milliseconds. When we just moved the lead to the distal his, we got a HV of 45 milliseconds. So this will essentially tell you that the diseased segment is probably between the location number 1 and location number 2. So when you place the lead just distal to the site of block, just like a surgeon putting a Lima graft distal to the site of proximal LAD stenosis, you'll be able to regenerate a normal appearing QRS. So we know the limitations of his bundle pacing. We are aiming for a narrow target. The lead dislodgement rates are very high, close to 10 to 15%, and almost 20% of the patients can have rising threshold and premature battery depletion. So this ultimately led us to think in terms of left conduction system pacing. Remember, doing left conduction system pacing is probably easy than his bundle pacing, but confirming the capture of left conduction system is little difficult as compared to his bundle. So for his bundle, it is all like yes or no, but for left bundle, it is a little a complex terminology, which every one of us should understand when you're doing a left conduction system pacing. So as a purist, I would always aim for a left bundle branch pacing, which indicates that you are capturing only the conduction system fibers. So it can be the proximal main trunk of the left bundle or one of its fascicle. It can be the posterior fascicle, septal fascicle, or anterior fascicle. On the other hand, left bundle branch area pacing is rather a vague terminology, which not only includes truncal or fascicular pacing, but also the LV septal pacing. Just to give an example, when the lead is hitting the left bundle, you'll be able to get a left bundle branch pacing irrespective of the pacing output. So you can pace at low output or high output when the lead is sitting on the left bundle, so you will have a consistent capture of conduction system. On the other hand, if the lead is a little away from the left bundle, only at a high output, you will be able to capture both the surrounding myocardium and the left bundle fascicles, But once you reduce the output, you will have a predominant septal capture. So these sort of capture, we tend to label it as a simple terminology called left bundle branch area pacing, which probably you can accept after multiple attempts in a patient with bradyarrhythmia and normal LV function. When the patient's normal LV function, when the LV function, baseline LV function is normal, probably left bundle branch area pacing can be accepted after multiple attempts of getting into the left bundle. But for patients with heart failure and white QRS, be it a left bundle branch block or right bundle branch block, it is essential for us to document the capture of conduction system, and it is always better to do left bundle branch pacing. For example, if I'm not able to show the capture of conduction system, left bundle capture, when the patient has a white QRS, I always put a coronary sinus lead to make it as a lot CRT. I will not depend purely on LV septal pacing for providing resynchronization in heart failure patient. Remember, your lead is not going to stay there for a long time. We have demonstrated by doing a serial CT angiogram that at the end of 6 months, nearly 5% of the lead can have a micro dislodgement, resulting in a loss of conduction system capture. So the lead is going to come back at the end of 6 months in 5% of the patient. So if the lead is deployed right on the LV subendocardium, just touching the LV bedpool, even a 1 or 2 millimeter dislodgement back into the RV septum will give enough capture of the conduction system. On the other hand, if your initial lead deployment is like this, even a 1 millimeter dislodgement will move it out of the left bundle, and this will result in a loss of conduction system capture. In fact, there is a recent paper in JACC EP where they had shown in an autopsy series that the real thickness of left bundle is going to be 1 to 2 millimeter. This again was confirmed in our CT study that you have a margin of 2 millimeter from the LV subendocardium to have capture of the conduction system. Coming in the tools of implantation. So we know that we are deviating away from the conventional position from the RV apical septum to the basal septum. So you need to have a specifically designed delivery catheter. It can be of a fixed curve or it can be of a deflectable curve with a probably especially designed leads. A lot of leads specifically designed for left bundle are coming. So all the industry partners have their own leads and delivery catheters for getting into the proximal septum to capture the left bundle, and almost all the leads and the sheath delivery catheters has been approved by FDA for doing left bundle branch area pacing. So this is how we start the procedure. The first step is almost always identify the His bundle, the distal extent, and have the imagination of this conduction system anatomy in RAO view so that you'll be able to deploy the lead either in the His bundle or in the left bundle. So anatomically, the left bundle can be identified by a zone 1 to 1.5 centimeter below the distal His towards the right ventricular apex. So you have to put the lead in the RV apex, you have to put the lead in the distal His bundle. Probably that 1.5 to 2 centimeter zone is the right zone to approach. Remember, if you go up towards the His bundle, that is a densely vascular area. You may be having a lot of septal branches. In fact, we had a case where we had injured a septal artery when the lead was deployed closer to the His bundle. So it's better to stay away from that initial 1.5 centimeter zone. So you can double confirm it by doing a ECG pace mapping on the right side of the septum. You have to get a W pattern in lead B1, which may be seen in 80% of the patient, and a discordant QRS complexes in AVR and AVL, and a predominantly positive QRS in lead 2. So this will guide us into the proximal main trunk of the left bundle. On the other hand, if you have a predominantly negative QRS in lead 2, you'll end up in capturing the posterior fascicles or the LV septum. Rather, a simpler way was proposed by Chinese, where they had divided the LV into 9 segments, and for in right anterior oblique view. So if you want to get into the His bundle, you have to go into zone 2, and if you want to go into the left bundle, you have to go into zone 5. So this is probably easy. You don't have to have an EP catheter, or you don't have to have a His bundle catheter to localize the His. Just partition the right ventricle in RA view into 9 segments and target the middle segment to get into the left bundle. So as I said, the most important step in conduction system pacing is anatomical localization of the His bundle. So if we can provide a virtual anatomy of conduction system like this, that where is the left bundle, where is the posterior fascicle, where is the septal fascicle, then it will be easy for us to deploy the lead wherever we want. We can put it in the left bundle, we can put it in the septal fascicle. So that we actually tried. We had actually reconstructed the CT angiographic picture, pre-procedural CT angiographic picture. And this picture will give the anatomy, a rough anatomy of conduction system fibers. And this can be merged with the fluoroscopy. And this will help us in better identification of the target zone. And you'll be able to deploy the lead either in the proximal trunk or in the septal fascicle or in the posterior fascicle, wherever you want, with the help of continuous visualization of the conduction system fibers. So as you identify the target zone in right anterior oblique view and double confirm it with ECG place mapping, the lead deployment should be in left anterior oblique view. So you have to pan from right anterior oblique view to left anterior oblique view. So I never deploy the lead in RAO view, though still some operators tend to do it. The LAO view will give you a better visualization of the lead penetration. That will help us in judging the position of the lead within the interventricular septum. And this is where we give a rotation. The rotation should be rapid. At least with the lumenless lead, you have to give rapid rotation so that it will overcome the inertia of the interstitial fibers or whatever there in the septum, and that will go deep into the septum in a comfortable way. So I always tell my second operator to hold the hub of the sheath, the butterfly hub of the sheath, in 4 o'clock or 5 o'clock position, so that it will give a good position internally with the septum. And you can see inside the heart, the sheath should form an L-shaped configuration. That tells you that the septum and the sheath are properly oriented to provide enough support. And dry hands are very important. In fact, I would probably give 50% score for a procedural success for a dry hand, because that will give enough grip over the lead. I'll start with the 2 powdered gloves. Just before deploying the lead, I'll remove my outer powdered glove so that I'll be wearing a fresh powdered glove in my hand at the time of deployment. So this is very important, and your sheath also should be like completely free of blood. Otherwise, any back leak from the sheath will make the whole area messy and you'll not be able to give rapid rotation. So for me, the main success for providing an adequate left bundle branch capture is identifying the target zone, probably the his bundle, and giving rapid rotation of the lead so that it can move into the septum quickly. So this is just a cartoon showing, this is just a real-time video showing how we deploy the lead. You can see the fluoroscreen pans from RAO view to the LAO view, and I'm giving rapid rotation. And you can see as the lead goes in fastly, you'll be able to see some ectopics. So this is because the lead, as it moves fastly, it irritates the myocardium, it will generate ectopics, and this ectopic morphology matches the location of the lead within the septum. So as you go towards the septum, the morphology in lead V1 changes from QS to QR as it reaches the LV side of the septum. So we call it as a PVC guided approach. We're doing it for the last 5-6 years. We found it comfortable in delivering the lead right into the left bundle with the help of this approach. So again, you need to provide a rapid rotation. This rapid movement will elicit PVCs, and this PVCs, so-called template beat or a fixation beat with an RBBB morphology, will tell you that you have reached the right spot. More specifically, when the template lead is having an M pattern in lead B1, we call it as an M beat. That tells you that lead is already hitting the left bundle, and that should be the ultimate endpoint. And the particular beat, the so-called M beat, is actually coming from the left bundle fibers per se, because this M beat morphology matches clearly with the selective capture of left bundle QRS morphology. So we can have a 12/12 lead ECG match of this M beat with the selectively captured selective left bundle captured QRS morphology. If we are not able to provide a rapid rotation, then probably you can go by the second way of delivering the lead by giving continuous rotation. This we more often use it for a stylet-driven lead and for left bundle branch pacing ICD leads, where we have to give slow but continuous rotation with pacing. So you have a stylet which can act as a holder for the clip, alligator clip, so that you'll be able to give continuous pacing while doing the rotation. Even with the lumenless lead, they have a revolving connector pin, which will come soon into the market, which will allow us to do continuous pacing while deploying the lead. So again, you have to see the QRS morphology. It changes from QS as the lead is in the right side of the septum to QR with a reduction in QRS duration as it reaches the left bundle branch zone. So overall procedural success will be close to 90 to 95%. The failure rates, so we analyze the reason for failure. The predominant reason for failure is going to be the inability to penetrate the lead into the septum because of scar or because of some sort of interstitial fibrosis. And in 1.5% of the patient, despite penetration, we were not able to capture the conduction system capture. All these are LV septum pacing. So this happened in 1.5%. But the most important thing is that cheesy septum, which is actually a real-time phenomena, where these patients will have a predominant normal LV endocardium. They'll have a normal LV function. And these group of patients had predominant AV blocks, where just simple rotation will result in over penetration of the lead. And within a couple of turns, you can see the lead hitting the LV lateral wall. So the septum will be so cheesy that it will penetrate so rapidly and it will not stay in the septum. So these 3.5% of the patients are very important to observe, because when you leave the lead in this patient in the interventricular septum, you can find the lead in either in the LV cavity or in the RV cavity on the next day, because the septum will not have enough grip to hold the lead. So this is very important to identify, because there are high chance for lead dislodgement in this group of patients. So we have classified the septal behavior because it's important to understand the septal behavior, not only for the acute procedural success, but also to measure the long-term outcome of lumbar branch-paced patient. So type 1 is luckily the most common septum. Irrespective of the LV function, the septum will be firm, and you have a typical screwdriver effect as the lead moves in from the right side to left side. Remember, as I give rapid rotation, I rarely give any push. You don't have to give a real push for deploying the lead. You give rapid rotation, just like a screwdriver penetrating the wall. The lead with this helix actually enters into the septum with the so-called screwdriver effect. On the other hand, type 3 septum, it will be a typical anterior my QR will be completely scarred septum, where the lead will tend to buckle, and whatever efforts you are going to put, it will not penetrate the septum. So these group of patients, it's better to go for a conventional biventricular pacing. So in between, we have this TC septum. You can see as I deploy the lead, within 1 or 2 turns, the lead will be just crossing the septum into the LV cavity. And as I tend to remove the sheath after deploying the lead, you can see the lead moves into the LV cavity. So the septum will be completely free of any grip. So you'll not have enough support from the septum. So it's better to avoid doing left bundle branch pacing in this group of patients, though echocardiographically, these patients will have a normal septum. So when you do a pre-procedural MRI, which we always do for all our heart failure patient, you will be able to gauge the septal thickness, morphology, scar, so that you can pre-plan the procedure well before getting into the lab. So it's our practice to do cardiac MRI for heart failure patients to identify the scar pattern, to decide about the resynchronization therapy, and to decide about whether the patient is going to get an ICD lead or not. So once you deploy the lead, it is our practice to confirm. It's important, in fact, all the more important to confirm the capture of left bundle. So I can say at least 17 or 18 criteria is currently available to confirm the left bundle branch pacing. But I'll go with this 3 important criteria, which probably I could say it is a simplified way of identifying the conduction system capture. So as you're capturing the left side of the septum, left bundle, you will be pre-exciting the left ventricle. So you should have a right bundle delay pattern in majority of the patient. So you can take this as a major criteria to have a right bundle conduction delay in the surface ECG as a major criteria. Remember, nearly 40% of patients with LV septal pacing will also have this so-called RBVV delay pattern. So you have to have one additional criteria to confirm the capture of left bundle. So this can be a short and constant LVAT, which we always measure in V6, or output dependent transition in QRS morphology. So short and constant LVAT, it's probably the quick way of confirming the capture. Remember, there is no absolute number which will guarantee that it is left bundle capture and it is LV septal capture. You should have a short and constant number, both at high and low output. This output dependent QRS transition, it's probably easy to identify it when you have an EP system, because you can blow up the sweep speed to make it to 100 or 150. You can see the typical change in QRS morphology. So your lead is capturing 2 different substrates with different electrophysiological properties. So one is the myocardial fibers, the second one is the conduction system fibers. So as you reduce the output, you'll have a change in QRS morphology as one of the substrate will lose its capture. So you can have different patterns of transition, selective capture to loss of capture, non-selective to selective to loss of capture, non-selective to myocardial capture or so-called septal capture to loss of capture, or when you do a his bundle pacing, you can have a high output non-selective his bundle pacing with correction, selective his bundle pacing with correction, selective his bundle pacing without correction to loss of capture. But when it comes to left bundle, probably the middle two is most important, NS2S or NS2 septal capture, and ultimately resulting in loss of capture. So let me show a quick example of this non-selective, selective, and septal capture. You can see the lead V1, V6, V5, and lead to look for the change in QRS morphology. So the local electrogram, you can see both the pacing artifact and the ventricular electrogram are crumbled. Here, the ventricular electrogram is pushed out of the pacing artifact when you have a selective capture, and you can see the change in QRS morphology. There is no S here, there is no S here during non-selective capture, but you can see an S wave as there is a selective capture. Similarly, in lead 2, it was all a tall R wave when there is a non-selective capture, but when there is a selective capture, there is a reduction in amplitude of the lead 2. So I didn't show the AVR here. The AVR will have more rounded configuration when it has a selective capture of left bundle. But what is more important as an electrophysiologist is to look for retrograde his bundle potential. You know that lead is sitting on the left bundle. So whether it is a selective capture or non-selective capture, when there is a capture of conduction system, there will be a propagation of impulse both down into the left ventricular myocardium and up into the his bundle. So even in patients with complete heart block, even in patients with a left bundle branch block, we have demonstrated that there will be a retrograde penetration of impulse back into the his bundle. So you can clearly see during non-selective capture and during selective capture, the retrograde hiss is clearly seen. But when there is a septal capture, which indicates that there is no conduction system capture at all, you're not able to see any his bundle potential. So demonstration of retrograde hiss double confirms that you are capturing the conduction system and it is not LV septal pacing. So the potentials can be manifest or concealed. Remember, the potentials can be picked up by the lead even away from the left bundle as a far field signal. So demonstration of potential alone will not tell you that you are capturing the conduction system and it is a LV septal pacing or a left bundle branch pacing. So we tend to get potentials in all patients when you see a non-selective to selective capture. But in patients with the baseline left bundle branch block, you have to do a his bundle correction by doing a high output his bundle pacing to activate the left bundle antigradely, and then you have to demonstrate the potential. See here, this patient has this is the rhythm, baseline rhythm, LBBB morphology, and when there is a high output pacing, here there is no correction of left bundle, but in this there is a correction of left bundle as identified by the narrow QRS and by a potential in the left bundle pacing lead. So the left bundle lead is already deployed. So I'm doing a high output pacing from the temporary quadripolar catheter, and as it corrects the QRS morphology, you'll be able to unmask the left bundle potential. So these are the endpoints for giving a rotation when there is a non-selective to selective capture, when there is a short and constant R wave peak time, when there is an appearance of M beat, and the unipolar impedance nearing 450 ohms. So all this would tell you that you are almost reached the LV subendocardium, and you don't have to give any further rotation because the lead is already sitting in the left bundle. So septal perforation is one of the most feared complications. In fact, it can be easily identified. When you identify it on table, when you rectify it, there won't be any long-term consequences. So most important thing to identify septal perforation is the current of injury. Forget about the morphology of the infiltrated electrogram, forget about the unipolar impedance because it tend to vary depending upon the lab, depending upon the cable, whether it is aux or new, or a lot of other factors. But the current of injury is constant. So if you don't have any current of injury after deploying the lead, please don't accept it. Remove the lead from that area because it had already perforated either micro or obvious. You put it to the new side. So once you're done, it's the practice to remove the sheath, just like the CRT sheath, which we remove it. So you have to remove it carefully, this left bundle sheath as well, because here we adapted a rapid sheath removal technique. Remember, the left bundle lumenless lead is very flimsy. When you do it slowly as you remove the CRT sheath, the sheath will also come up. So it comes sometimes. We'll pull the lead up. So we had some instances where the lead was pulled out of the septum when we removed the sheath slowly. So we adapted this rapid removal technique initially with the lumenless lead. Subsequently, with the lead, with the stylet-driven leads, now even the CRT sheets are removed in this rapid way. All you have to do is the initial hub should be taken care of. That part should be slow, and after that, when you fix your left hand firmly and right hand firmly, and you can just rapidly pull the left hand, the sheath will come out easily without disturbing the lead. We know why we are doing so resynchronization. The resynchronization left bundle, or for that matter, even the his bundle will be beautiful. You can see a beautiful synchronization of the left ventricle between the lateral and septal wall, and excellent reduction of functional mitral regurgitation as early as 10 days to 14 days, even before the LV had remodeled. So all this would favor probably the left bundle over the conventional biventricular pacing, but we need to have a randomized trial. So that's all in the future now. So we have to have a randomized trial. So any new scientific discovery needs good evidence-based medicine to practice into the day-to-day, to get into the day-to-day practice. Probably in the future, with the availability of better sheets, better leads, and better technologies, in the future, probably we'll be doing left bundle as a predominant technology, both for right ventricular pacing as well as for heart failure patients. So we have conduction system pacing for atrium as well, where you can capture the Bachman bundle, and we can combine both the Bachman bundle pacing and left bundle branch pacing. So at least in patients with heart failure with a reduced LV systolic function and associated diastolic dysfunction, this Bachman bundle pacing along with left bundle will definitely give a better long-term outcome. So probably in the future, we'll be having ICD leads getting into the left bundle, and even a lumenless lead, leadless pacing leads getting into the conduction system pacing. The future is bright probably, but we need to understand the basics. We need to understand how the technique is done. And at the most, we need to start with the his bundle pacing, because that helps us a salvage technique in some patients where there will be a difficult setup. Thank you very much for your patient listening. We're happy to accept the questions.
Thank you, Dr.
So,
SMS. That was quite comprehensive. Dr. Aditya, Dr. Rajiv.
Yeah.
so excellent presentation, sir. Sir, in one video you have shown LV angio also. So you do routinely LV angio, or it's just to show?
LV angio, sheath angio, usually we stop doing sheath angio. LV angio rarely do. The sheath angio, the problem is when you're doing sheath angio, you have to pull the sheath little back. Otherwise, with the sheath well opposed to the septum, when you do it forcefully, you will dissect the septum. A lot of instances of sheath hematomas and venous sinusoids getting filled from that forceful injections. All this we have seen. So we don't do sheath angio routinely unless there is a complicated anatomy. For example, if the patient has a CCTGA or situs inversus or a kyphoscoliosis, where we need to know the orientation of the septum. Otherwise, we don't do sheath angio at all.
Superb lecture, Shanmuga, as always. So many thanks. Just a brief word from you. What about mandatory pre-procedure echo? Do you measure the septal thickness and stuff? Do you still do that, or?
Yes, sir. Yes, sir. Still, I measure the septal thickness and see the morphology of the septum before getting into the lab, before getting into the case. So we always have a bedside echo machine in majority of the labs. Measure the septum and measure this thickness so that you will have a rough idea of how deep you have to go inside the septum. And the texture will also is guide us whether it is going to be a tough case or an easy case. So it's
So
our
what,
custom practice. Yeah.
what cutoffs would you tell to the audience? I mean, when you would probably not do, or when it would be a concern for you in terms of a very thick septum?
So there is no cutoff for doing left bundle branch pacing, whether it is a 4 millimeter septum or a 30 millimeter septum. You can do it unless the patient has a scar in the myocardium. So in a pediatric cases where the septum was 4 or 5 millimeter, we tend to go obliquely so that we can deploy more additional length of lead inside the septum. And in a thick patients like hypertrophic cardiomyopathy, you may have to go all the way deep into the septum, so you know how deep you have to go. But there is no specific cutoff. Rather, a scar is the limiting factor for deciding about the procedural success.
Sir, how often you get M-beat?
Yeah, so that is probably it comes with the practice. So we had 3 different papers on MBEAT. The first paper we had success. MBEAT was in 30%. The second paper, it was in 60%. Now almost like 85% of the patient has an MBEAT. And again, it depends on whether you're getting a non-selective to selective transition. So when we started, it was around 60-70% of the patient had non-selective to selective transition. Now almost like 95 to 96% of the patient will have a non-selective to selective transition.
So once you see M-beats, do you give more, one or two more turns, or you stop there?
No, I'll stop there. You don't have to give additional rotation. In fact, one thing which I have not discussed there is something called LV subendocardial cushion. It is well developed in nearly 90% of the patient. In fact, there is a beautiful article from Marek about this of the postmortem in the cadaver studies of lead behavior. So where he had shown that there is some LV subendocardial cushion barrier which will prevent perforation to some extent. In fact, we had seen in a real-time video where we had given enough rapid rotation, and we are not robots to just calculate the number of turns. We'll give it rapidly and randomly. So if the lead had reached that LV subendocardium, whatever be the additional rotations you are going to give, sometimes the lead will not go in, provided the rotations are not really aggressive, because there is some cushion effect which will prevent further penetration into the septum. And when you have a salvos of ectopics, this M-beat will be the last generated ectopic. And even if you give some additional rotation, you will not see any ectopic of different morphology. So that means that there is some cushion effect on the LV subendocardium, which prevents the perforation of the lead into the septum. So only if you give aggressive additional rotation, the perforation occurs. And this cushion effect we had observed with the tactile feeling in nearly 90% of the patient.
So, Dr. Shamum, sir, you're an idealist, you're a purist, as mentioned by yourself, that you will stick to as strictest as possible of the criteria to ensure the maximum success. But practically for especially early career cardiologists coming out, these practice, the lab they practice, the places they practice, there could be challenges involved. Non-availability of even a 12-lead ECG, how do you go around? That's exactly where Dr. Sanjay's talks come in. He's going to join us and talk us more about what are the other simplistic ways of, we might not truly call it left bundle branch capture, but at least left bundle branch area pacing. So in a very simplistic way, what would your advice be to the outgoing DM/DNB students, cardiology students, when they want to start off with left bundle branch area pacing? Not to get bogged down with all the details, how to keep things simple. Simply in a minute or so, you can explain this.
Yeah, so probably for bradyarrhythmia patient, the ideal way to start is to start doing it in bradyarrhythmia patient, probably a nodal block where you'll be able to see a disease-free distal conduction system. And in bradyarrhythmia, I think even 20 DCG is good, so you don't have to really have an EP system. But I would advise all the persons whoever is doing the procedure to do it with at least a 20 DCG machine, because if you don't have even a 20 DCG machine, then I think you're not doing any justice for the patient. So you should have at least a lead V1, you should have at least a lead V5, and probably I will add lead 2 as an additional thing to decide whether you are captured the left bundle trunk or fascicles. But at least lead V1 and lead V6 should be there to demonstrate that you are capturing the left bundle patch area at least, and not it is mid-septal pacing. So you can do it with the 12 DCG, go as deep as possible. And if you don't have a 12 DCG, you can connect the treadmill machines. We are done with the treadmill machines in some of the centers, and it provides the luxury of increasing the sweep speed. You can always increase the sweep speed, pause it, you can take some pictures out of it immediately, and you can measure the duration roughly, and you can show whether the LVAT is short and constant. So I would always tell them to do with an ECG machine, whether it's an absolute 12 lead or some cath lab itself will have, I think Philips monitor has some 12 lead ECG connections, or at least with a treadmill machine, which gives us some information about left bundle branch capture. But for heart failure patient, I think whenever you are doing it as an alternative for CRT, specifically when you are going to leave the patient with a left bundle lead alone with a dual chamber pacemaker, you have to be purist. There is no other option. You have to do it with an EP system.
Great. I would request you to quickly answer the questions. If you can type it, it would save our time. And as we move on to the next presentation, Dr. Amit Malik has a question. Surendra Tiwari has 2 questions. It would be great if you can type those answers to them, sir, and so that every one of us can also see it. Meantime, we can, yes, Dr. Rajiv, please introduce the next speaker and we can go on.
So our next topic is Simplified ECG-guided approach by Dr. Sanjay to achieve effective left bundle area pacing. So I invite Dr. Sanjay to deliver his talk. Dr. Sanjay, please.
Yeah, thank you, IHRS Deep, Jay sir, Kapoor sir, and Shanmuga sir. He actually, our association goes way back. Probably I was introduced to Shanmuga sir as a proctor when he helped me do left bundle branch pacing to one of my patients maybe 5 to 6 years back who had failed his bundle, and there was no looking back since then. So I have a couple of questions to Shanmuga sir. I'll do it at the end of this talk. Uh, so the simplified ECG-guided approach to left bundle branch area pacing. So Dr. Shanmuga showed us the anatomy of the conduction system. So just to go through that again. So you have the penetrating bundle of his which runs in the membranous septum and which divides again into the left and the right bundle branch. So it's very interesting to note, as Dr. Shanmuga mentioned, so you have the left proximal bundle as well as the left fascicles. So they run very close to the left ventricular subendocardium. So they are almost at the other end of the interventricular septum. And to truly capture the left proximal bundle or the left fascicle, you see that the lead has to traverse across the entire breadth of the interventricular septum and touch these conduction system fibers to call it conduction system pacing. And now with left bundle branch area pacing, you have the concept of proximal left bundle branch pacing, you have the left fascicular pacing, and you also have the left ventricular septal pacing. But in a pure sense, as Dr. Shanmuga mentioned, even I'm a purist, LV septal pacing is not conduction system pacing because you don't achieve the same hemodynamic effects with a pure LV septal pacing compared to a bundle branch pacing or a fascicular pacing. So you have numerous criteria for left bundle branch pacing. It was clearly elucidated by Dr. Shanmuga. You have the V1 RBB pattern, you have the fixed and constant LVAT, and you, as he mentioned, there are numerous criteria. But why do we actually need these criteria? So these criteria were actually, they were enforced to distinguish pure conduction system pacing, that is left bundle branch pacing or left fascicular pacing, from LV septal pacing or deep septal pacing. And for this, in a true sense, you do need an electrophysiological system, an EP system, to see potentials and to measure intervals. So again, so why you need the EP system? One, you have a clear visualization of the 12-lead ECG. You can measure the intervals quickly because you need to measure in millisecond the left ventricular activation time, whether it's less than 75, 80, or 90. And you can also visualize intracardiac electrograms with the EP system. But a fully capable EP system is not universally available. And so when you look back at it, so the specific criteria for left bundle branch capture, some of them only require a 12-lead ECG. Namely, you need a change in the morphology from a left bundle branch pattern to RBB pattern, particularly in V1. And you need to measure the left ventricular activation time, probably at a sweep speed of 100 in lead V6. And again, for the interpeak interval, you can use a 12-lead ECG. But measuring intervals in millisecond, you cannot do that in the EP lab. Connect the patient to an ECG, keep recording at a sweep speed of 100 or 50 millimeter per second. It would be too cumbersome. So the other alternative for this was using a pacing system analyzer. So this is the machine which the pacemaker techs would have during the procedure. And if you closely look, I would request all the fellows or the DM trainees or even the young cardiologists to go and have a look at these machines. So you can actually connect this machine. It has a cable. You can connect it to the patient. It would give an ECG lead, and you can freeze the ECG lead. You have calipers, and you can have a sweep speed to slow down the speed of the ECG recording, and you can adjust these calipers to actually measure intervals. So this could actually help during conduction system pacing, and this was the recent document from the EHRA consensus document on conduction system pacing, meaning that during a conduction system pacing, ideally you need a 12-lead ECG and an EP recording system. It could be appropriate that if an EP recording system is not available, at least to use a 12-lead ECG with the PSA. You should definitely not fall short of that. You cannot do a conduction system pacing with less than a 12-lead ECG. So this was our paper. This was what this talk is going to be based on. So we used how this came about was that when we tried to do conduction system pacing in peripheral centers without an EP system, so we used the ECG leads from the treadmill machine because there were basically crocodile clips which were connected across the chest leads and the ECG leads from the pacing system analyzer. And in combination, we were able to give the patient the benefit of conduction system pacing. And so I'll go on to, before that, I just want you, the young cardiologist there, to understand how an ECG lead is derived. So any lead which is derived from the ECG, you have the reference electrode is basically what the exploring electrode is looking at. So it's like a cameraman taking a click of the heart in a particular orientation. So you have the limb leads where the exploring electrode for lead 1 would be the left arm. For lead 2 and lead 3, the exploring electrode would be the left lower limb, whereas the reference electrode would be the other arms. For the augmented limb leads, again, the exploring electrode would be the right arm for AVR. For AVL, it would be the left arm, and AVF would be the left lower limb. So this is how you get various orientation of these leads, the vectors of these leads. And if you clearly see both the inferior leads, that is lead 2, 3, and AVF, the exploring electrode is the left lower limb, which is a constant. So this is a lead which is looking at the heart from the inferior surface. That's why you call them the inferior leads. And if you look at lead 1 or lead AVL, the exploring electrode is the left arm, which is looking at the heart from a lateral projection. So that's how you get 0 degrees and minus 30 degrees for the AVL. So the chest leads, it's interesting here because the reference electrode is not any of the other limb leads, but it's the Wilson central terminus. The Wilson central terminus is computed by connecting the 3 limb electrodes via electrical resistance, and you get an average which is somewhere within the body cavity. So the Wilson central terminus is a virtual electrode which is present within the body cavity, and that is the reference electrode for your chest leads. For example, the electrode V1, we know it's placed in the left fourth intercostal space. So the potential difference from the Wilson central terminus, and this is the exploring electrode, you would derive the ECG lead for V1. So in our study, we did a prospective pilot study. We studied it in 19 patients in centers where we didn't have an EP system. So we used the 12-lead treadmill test ECG machine. So we used this for simplicity because we knew that these ECG electrodes had crocodile clips which were easy to be connected to the patient. And it was out of ease of access that we used the treadmill machine. And we also use the ECG leads from the Medtronic as well as the St. Jude systems. So when you have the Medtronic system and most of the other system other than Abbott, so the PSA would have 4 leads, and this could give us 3 channels on the PSA, which was lead 1, lead 2, and lead 3. So this was the interesting part. So we wanted, as Dr. Shanmuga clearly mentioned, you need a V1 and you need a V6 to measure the LVAT. V1 to see the transition where you're going from a left bundle branch block pattern to a right bundle branch capture pattern. So what we did was we placed the left arm and the right arm electrode in the right fourth intercostal space, and we placed the right lower limb and the left lower limb in the left sixth intercostal space. So this resulted in a modified lead because we know that left arm to right arm is the lead 1. So this is not a true V1, it's a pseudo V1 because it's a bipolar type of lead configuration because it's just 2 close leads which are close to each other. And again, from left lower limb to the right arm, which is lead 2, the lead 2 gave us a pseudo V6. So, but we had to use the 12 lead from the treadmill machine to determine the site of the initial screw-in. And Dr. Shanmuga alluded how we need 2 positive, a 3 could be an RS or a negative, but you need an AVR which is negative or an AVL which is positive. So this is the site we typically aim to target. This is the right anterior septal surface. Sometimes as you counter your sheath too much, you could capture the septum, but it could be more of a posterior septal capture where you would still have AVR which is negative and AVL which is positive, but you would see 2, 3 and AVF more having negative leads. So mind you, so we have not yet started screwing in the leads, so we are determining which side of the septum we need to target. So the previous was the anterior septum, this is posterior septum, both are okay. But sometimes what could happen is if you clock your septum too much, you could have this kind of a morphology where you have positive vectors 2, 3 AVF However, you would see that AVR and both AVL is negative. So the contrast is here. You have a negative in AVL, which this means that this is not the septum. Your sheath as well as the lead has gone to the right ventricular outflow tract. You need to drop the lead as well as the sheath down towards the septum to achieve, at least to start drilling in the lead. So, and then, so once we determined we had the lead at the proximal septum, lead advancement was done by rabbit turns, as Shanmuga mentioned. And so this was a representative case where we had done the case and we used the same leads to show what we had done. So this is the left arm to right arm. So you have here where you see the lead one. So this is the QR morphology, which corresponds to the QR which you get in the 12 lead ECG. And to measure the LVAD, so we use the lead 2, which is the left arm to the left lower limb to the right arm configuration. You have the lead 2. We used to sweep a speed of 100 and then froze the screen to measure the left ventricular activation time. So with the other system, the St. Jude Abbott, we had a distinct advantage because Abbott has 4 leads along with a chest lead V1, and this results in the derivation of several channels. So you had all the leads 1, 2, 3, AVR, AVL, AVF, as well as V1 from the system, and any of the 5 channels could be displayed on the PSA at a time. And what we did was we just connected the V1 to the regular V1, and we connected the left arm at the left 6 intercostal space, so that, and we use the AVL as a pseudo V6. So again, Dr. Shanmuga mentioned how during stillet driven leads you could connect the crocodile clip, that is the distal cathodal crocodile clip, to the stillet, as well as the same time do the rotations. And this allowed real-time impedance and ECG monitoring during lead advancement in the septum. And this helps us to visualize screw beats, and it helps us to, so this is what we see. So this was again a representative case. This was the 12 lead treadmill ECG, and this was what we saw on the PSA. So this was how the PSA was set up. You had the chest lead, you had the AVL here. So during, as rotations were being given on continuous spacing, you can see real-time impedance monitoring. You can see 2 beats. These are V-sense beats, and these were the typical screw beats of the RBB morphology. And then you had the change in the pacing from an LBB to an RSR pattern, which again corresponded in the 12 lead ECG as well. So again, you had the screw beats, you had probably a smaller R prime beat and a bigger RSR in another implant. So we did an analysis. We looked at the LVAT measurement from the PSA and the QRS duration measurement from the PSA and compared it with the measurements in the 12 lead ECG, and there was excellent correlation, and which also proved clinically helpful to the patients and to the centers we were doing. So another interesting study which used the exact same orientation of the leads. This was from Turkey, which was recently published in JICE in March. So what they did was they used the same configuration, but they did it in an EP lab, and they again they checked how well the measurements from the PSA correlated with the measurements due in the EP lab, and again they had excellent correlation. Almost in 100% of the case. This was with around 85 patients from Turkey. So what are the clinical implications? The clinical implication is that, for example, so this was a case, one of my, I had to go in as a proctor to a nearby town. So a 65-year-old woman with history of CRTD implanted for non-ischemic DCM in 2012. The LV lead had dislodged in 2012 shortly, and she underwent a surgical epicardial lead. She came with recurrent ICD shocks due to an RV lead fracture, high thresholds of the LV lead, and so she was planned for a CRTP upgrade. So unfortunately, the CS, it was a bald CS. You did not have any veins, multiple attempts. So, and this is what we could achieve with left multiple branch pacing. So we used the same system. We had a 12 lead ECG put up, and we used the PSA to achieve conduction system capture. And thankfully, this is what we could do. So this was the native 12 lead ECG of the patient before the procedure, and this is what we were able to achieve with proximal left multiple branch pacing. So the workflow, again, just to reiterate, so you need a 12 lead ECG along with the ECG for the PSA for determining the site of the initial screw-in. So as we know, the AVR and AVL discordance and the positive R wave in lead 2. And with the Medtronic and all the other PSA systems except Abbott, you have basically 3 channels, and you connect the right arm and left arm below V1 and the right leg and the left lower limb below V6. So you get a modified V1, which is lead 1, and a modified V6, which is lead 2. And with the St. Jude Abbott system, the interesting part is because you have all the other leads, even for the site of initial screw-in, you could use the PSA. And for the modified V1 is the chest lead V1, and the modified V6 is the lead AVL. So I was asked by Deep to again just talk about a couple of other studies which we had done in the recent past. So this was with Ullas sir. We looked at left funnel branch area pacing in hypertrophied septa. And in a series of hypertrophied was meaning significantly hypertrophied with septal thickness more than 18 millimeter. And over experience, we found that still-driven leads had a slightly better I would say success profile in this group of patient, and this was the brainchild behind this study, which we had done recently at the Royal Adelaide Hospital. So we aim to look at the biomechanics of the leads of the lumenless lead and the other still-driven leads in thick septum. The initial plan was to actually do a cadaver model, get a patient with hypertrophic cardiomyopathy and a cadaver, and look at lead biomechanics like how Marek had done with normal heart. Unfortunately, it was difficult to source cadavers here. So we did a sandwich model where we used ovine atrial ventricular septa, and we sandwiched 2 septae, one on top of each other, and we put them in a clamp, and we drilled these leads onto the tissues. And as we were drilling, we used a custom made rig which could measure the torque force in these leads. And it was interesting because the torque graph again showed what Marek had previously described. You have the endocardial barrier effect where we had the lead entangling with the endocardium, and you had the drill effect where the lead goes into the septum, and then because there's no forward force going in, you had the lead drilling around itself, and then it creates a wide bore, and then it just comes off. And you had the screwdriver effect where the lead kept progressively going in. A very interesting concept which we noted, particularly with the 3830 lead, was that in very thick septae, so these septae were almost 14 and 14, almost 28 millimeter, and we know that the 3830 has a 1.8 millimeter helix, and then 9 up to the anode, another 1.7. So around when you had 14 to 16 millimeter of the lead of the 3830 lead in, which was mainly when the anode was buried into the septal tissue, no matter what amount of torque you had given with the rig, you had continuously rising torque, meaning that there was no torque transmission to the lead, causing the lead to further penetrate into the septum. And we describe this as a myocardial barrier effect, meaning that the thickness of the septum itself beyond a certain level could impede lead progression and could affect torque transmission with the 3830 lead. And this was not seen with any of the other still-driven leads. So this was interesting. And these were some of the pictures. So this was the screwdriver effect where you had lead penetrating through and through up to the endocardial surface of the other side. This was the endocardial barrier effect where you had crimping of the septum, just the helix getting caught in the surface of the tissue. And this is a drill effect where you had a bow occurring around the lead helix as it's being rotated. And this was the myocardial barrier effect where you can see once the anode has been wedged into the septum, it was very difficult for further penetration of the 3830 lead into the septal tissue. So I'm sorry I took extra time, but Deep had just kindly requested me to go through these 2 papers, and that was the reason. Thank you.
Excellent. Excellent. Shanmugam, sir, you have anything to talk about these papers? One was the modified lead placement, and number 2 is the biomechanics of the leads, stylet driven versus lumenless leads.
Yeah, I think the modified lead placement technique is quite useful for those who don't have an EP system as of now in their lab, especially in the peripheral areas where we go for proctoring. We will not be having a standard EP system to guide us. And probably this will be sorted out in the future because all industry partners are coming out with a dedicated programmer for conduction system pacing. And so that will have integrated stuffs, everything what we want to have it in a programmer, what we now we are having it in the EP system will probably in the future be integrated into the programmer so that we don't have to really worry about having an additional EP system to do it. And but as of now, since it is not available, I think these modifications will definitely help us. So at least in terms of confirming that RBB delay is there, whether it is an LV septal pacing or an L-bundle batch pacing, at least RV septal pacing will help us. So this should be the standard thing for doing a procedure without EP system. And for the hypertrophic septum, yeah, so it's really difficult to penetrate the tough septums, and majority of the times you might have penetrated it quite deep, but still not be into the septum because not all leads will go perpendicularly at 0-degree plane. So even if it goes perpendicularly, the heart may not be like this; it can be like this. So some part of the lead will go obliquely, drilling the septum across rather than through into the septum. So we may be deploying a very long length of lead inside the septum. So ultimately, when you track the lead with the help of electrophysiological parameters, you'll be able to confirm it. But I feel there is one danger in it because we had seen one fracture of lumenless lead proximal to the ling electrode. As we deploy more length of lead, at least in hypertrophic cardiomyopathy patient, with the jerky contractions, I had immediate post-implantation fluoroscopy and all will be looking really dangerous because the hinge point will be in the lead rather than at in the distal end of the lead rather than at the ring electrode junction. So where there will be a high chance for future lead insulation failure or fracture. So you have to follow these patients very carefully, especially in patients where they were pacing dependent. I think it's important to follow this patient very carefully to look for any breach in insulation at the earliest and to correct it immediately.
Ajay, sir, you
No,
have
I
any
think it
points to
was
add? Yeah,
pretty good and
especially for the
comprehensive.
youngsters. Yeah, for the
I think next
youngsters,
thing we can move
yeah,
to
who are
the
coming
new
up.
case.
Yeah, okay, fine, great. So we are moving up with Dr. Saroj. Will be presenting one case on left bundle branch area pacing, and that will open up a few questions for discussion. And then Dr. Shanmugam and Dr. Sanjay can answer the questions based on the case. Saroj, please go ahead with your presentation.
Good afternoon to all. Thank you, Dipchand sir. Am I audible, sir?
Yes,
Yes,
please
you
go
are.
ahead.
Yeah.
Thank you, Dipchand sir and IHRS for giving me this opportunity. And I am going to present a CSP case for a heart failure patient. So my patient is 70-year female with repeated history of repeated heart failure hospitalization, recently admitted for complaints of heart failure. And the patient is undergoing, there is atrial fibrillation with fast ventricular rate, which was unable to control with medications, and we failed to achieve sinus rhythm with pharmacological or electrical cardioversion. The echo shows dilated LV, global hypokinesia with severe LV systolic dysfunction. So we planned for a AV nodal ablation followed by a left bundle branch area pacing. This was the baseline ECG. Then we perform a AV node ablation. And this is the after ablation ECG. So now I am going to demonstrate that conduction setup pacing step by step with the fluoro and that EP guided methods. So First, the dilator and the sheath and dilator combination is taken over the wire into the LV. Then the both dilators and wires removed and the sheath is placed in the RV. Then the lead is taken into the RV and the lead is exposed beyond the sheath, and the lead is redirected into mid-basal septum 1 to 1.5 centimeter distal to the hinge location. Now, unipolar pace map is done, and the unipolar pace map shows V1 with a W pattern, lead AVL and AVR discordance, and lead 2 and 3 shows both negative 2 and 3 QRS, most probably due to left posterior fascicular capture. So now the lead orientation is checked in LAO 30 view, and the lead sheath and the helix is exposed. After the helix exposure, the lead locking tool is placed, and we proceed for the screwing of the lead into the septum. This video shows screwing of the lead into the septum. This is the ECG. The W pattern is now disappearing, and the leads, the notch is ascending into the lead is ascending gradually. Then further rotation. With further rotation, the terminal, the QRS gradually narrows, and the terminal R wave is appearing on the V1. Then with more rotations, the QR pattern it becomes more prominent, and there is transition from QR to small q and big R pattern. So this is the during the threshold testing, the threshold was 1 volt, and after the threshold testing, the slitting was done. But interestingly, after that slitting, the helix got retracted and the left bundle capture was missing from the ECG leads. The R wave disappears and the screw, the helix got retracted and the R wave disappears after slitting. So we tried to expose the helix without repositioning the lead. Same position, we just expose the helix. and the R wave reappears in the V1. So before we finally securing the lead, we tried to check the stability of the lead by giving a alpha loop Further lead stability were cross-checked by lead manipulation. And that then threshold testing was done, and the QR pattern persists at 1.5 volt. And the current of injury was also good, and lead impedance was also good. This is the final position check. The final threshold testing, and QR the threshold was 1.3 volt at this time. The LVAT was 72 milliseconds. It is from pacing spike to peak of the R wave in V6. And that V6 V1 interpeak interval is also calculated and found to be 60 milliseconds from V6 peak R to V1 peak R. The final lead position. And this was the after the device connection in the bipolar mode. Also, thank you.
Thank you, Dr. Saroj, for sharing the case. Yeah. So we are moderators, please give in your comments, your tips, 2-3 more minutes, and then we close our topics.
Yeah, so I'll just give some one or two comments. It's a beautiful case, and with the style-driven leads demonstrating non-selective to selective transition is it's excellent, and the ultimate result was really good. There are one or two important things which it's very important here whenever we are doing ABJ ablation. You know, it's a very good choice for controlling the rapid ventricular rate in patients with permanent AFib. So we always put the conduction system lead first, then we ablate the AV junction so that while implantation, it will be easy for us to demonstrate the capture of conduction system with the sinus rhythm. So when you ablated it, probably you'll be having a pace rhythm which will be going on, and you'll not be able to demonstrate the potentials and other important parameters which are important to confirm the capture of conduction system. So what will be the heart rate even with 110, 120? You'll be able to put the lead comfortably, and then you can ablate the AV junction. That's our way of doing it, but whatever way the individual person prefers, they can do it. And it should be a combined procedure which can be done on the same day. Some people used to stage it like they want to get the lead to get matured for 6 weeks, then they do the ablation, but we always do it on the table. So put the lead, confirm the capture of conduction system, then ablate it either from the same puncture up. You can have 8-1 sheet over there. You can put the ablation catheter right from the subclavian vein into the RV and ablate the AV junction, or you can go down from the groin and ablate the AV junction. Then you can come up, close the pockets. That's how we do. And the other important thing is, as far as the styler-driven leads are concerned, this is one thing which is really a major concern during long-term follow-up. So even on table, we could see the helix coming back, and this happens more often with Biotronic and Boston, where they don't have a helix locking tool, but it happens very less frequently with Abbott tools, and they have a good, excellent helix locking tool, which makes the helix stable throughout the procedure. So this is Because at least he could get the capture back. In fact, after redeploying it, he had some demonstrated the non-selective to selective transition as well. That means that the lead had not moved anywhere out of that site, just it was a helix retraction. But that is a real concern. We don't know what happened to this patient during follow-up, because as the helix has the tendency to come back, this can happen even during follow-up as the patient goes out of the cath lab, out of the hospital. We don't know what will happen during the long-term follow-up. So we tend to prefer this lumenless lead for heart failure patient, where there should be a consistent capture of conduction system. But as far as stylet-driven leads are concerned, there is a little higher incidence of loss of conduction system capture. So we have to be very careful in choosing the right tool for the right patient.
Great, sir. Sanjay, you have anything to add on this, especially with particular details to this case?
Yeah, I think as Dr. Shanmuga mentioned, the reality with retraction of the helix is always there, and it's definitely wise to check again at the end of the procedure in two views, making sure that even if it's not partially retracted, that often happens. And the only advantage is you can give further turns even if your sheath is out. You can extend the helix like how Saroj was able to do in this particular case. Yes, but even I also prefer the lumenless leads in upfront, and it's been there with the longest follow up, and we really don't know the follow up with these with the newest stylet-driven leads in particularly in the deep septal locations and other locations as well. And the other issue we all know is with lead fractures, which are more common with the stylet-driven leads, and in fact more common with the biotronic, because if you actually handle the biotronic leads compared to the other leads, you would see the junction between the anode and the lead helix. You would actually feel the flexible portion of the lead, which is it's so supple. You can actually bend the lead almost to 90 degrees, and so that's a real concern with the biotronic solia leads. But I think there are implanters, and some of them recommend a tangential orientation during implant, and making sure that it's not too oblique. But yes, I do have my concerns with some of the leads, as Dr. Shanmuga. I would like to hear Dr. Ajay sir's views on this.
Yeah, we are still having a lot of variation in the way hardware is handled. We don't have dedicated leads for this conduction system pacing. These are all leads developed for something else, and we are adapting those. Still a learning curve. The helix fixation tool is something which all the companies are now introducing, so that may help. But I guess we are learning.
And another point I wanted to add. So when we did the lead biomechanics study, we used to give, because the septa were very thick, we used to give excessive torque just to see how resistant the leads were, and almost all the leads had insulation break and insulation damage. It was most noted with the Abbott Tendril lead as well as the Boston leads. Surprisingly, the insulation with the 3830 was surprisingly good, in spite of the torque rising within the lead to be the most highest. We didn't see that degree of insulation damage with the 3830. That was one. And the other lead which we thought did as well as the 3830 with regard to the insulation was the new lead with Abbott, the Altipace lead. And the Altipace, I think they've given an extra layer of polyurethane. They've remade the lead, so that looked a bit more sturdier than the Tendril or the Ingevity. So that was our observation on the table as well. So it's always good to inspect the lead body as such. If you keep using it repetitively during a tough procedure, multiple attempts, to look if there is insulation crimping, particularly with the Abbott tendril, the insulation crimping, sometimes it's permanent. You see, you can actually feel the crimping on the lead, and you should definitely change the lead at that point. That's another thing. Thank you.
Ajay, sir, I think that was a fantastic presentation today. We can close the presentation with your final remarks, sir.
Sure. I think this was a fantastic session today. Covered everything from basics of ECG EP to left bundle branch conduction system pacing, right from basics to a nice case in the end. We've overshot the time, but pretty good presentations today. Thank you, everyone. Thank you, Dr. Deep, for doing this.
Thank you, all
Oh,
moderators,
just
and
one
thank you,
more thing. We
speakers.
have the
Yes, sir.
midterm IHRS coming up
Yeah.
last weekend of this month. That's 26, 27 July, I guess. Yeah, and it's online. It's conducted by Dr. Ajit Thachil, and it's basically regarding imaging in electrophysiology. So everything from MRI to CT to everything. So that will be pretty good for everybody to attend.
When is the date, sir?
26, 27 July,
Thank you, sir.
last weekend.
Thank you.
Thank you, Dr. Deep. You can wind up, I guess.
Thank you, sir. Thank you, Medgami, again for your support and for your cooperation in making this happen. We will conclude the webinar here. Thanks all speakers and moderators.
Thank you, sir.